right now, we have a 30-bedded de-addiction center at our A.V. Baliga Memorial Hospital. It was started in 2005, 2006, and it was inaugurated by our ex-Vice Chancellor of Mahe, Shri B.M. Dr. B.M. Hegde. So I start with how we started this de-addiction thing. Basically, de-addiction, it was more out of my own necessity than real interest. I did not choose de-addiction as it was not something which was as a student very appealing or anything like that. But when I came to start my practice in psychiatry in Udupi, there was no psychiatrist who was working in de-addiction. There was a department, my alma mater, KMC Manipal. Then there was my teacher, Dr. Shripati Bhatt, in private practice. Then there was one more psychiatrist in Kundapura, Dr. K.S. Karand. So at that time, there were there was nobody who was working in this area of alcohol de-addiction. And as I did my post-graduation in Manipal, I knew that this is one thing where there may be a lot of scope. So at that time, admissions were being made for alcohol de-addiction in general hospital setup, and there was no help or no assistance. So initially, when I started off with the private charitable hospital, that is the CSI Lombard Memorial Hospital, the first idea which appealed to me was starting a separate ward for alcohol de-addiction, and the then director there, Dr. Ashok Ronad, he was also equally enthusiastic. So he gave me a small old ward. It was a 7-bedded ward, and this is where our de-addiction program started. So at that time, I needed to create awareness, because basically this strategic planning, I would say, would start from awareness. See, what I feel is one thing is many people want help in de-addiction, but they don't know where to go. In fact, when I started the setup, there was nobody. In fact, in Mangalore, there was one, this one called as Link Trada. Then there was a Velankani ward. This is almost around 80 kilometers from Udupi. These were the only two places where alcohol de-addiction facility was available. So ours was the third facility which started in Udupi district. I mean, the first facility in Udupi district, but undivided South Canara, there were other two. So I started off with awareness programs. The awareness programs were in this Grama Sabha and our own hospital department, because our CSI Lombard Memorial Hospital was known for a busy medicine department and obstetrics and gynecology department. So what I used to do is conduct awareness talks about what is this alcohol de-addiction, how is it being done, and what can be done, these sort of things. And of course, second thing was approaching our own GP clinics. Basically, Udupi district has both Ayurveda as well as MBBS practitioners. And I think if you look at the ratio, Ayurveda people are more. So I visited each and every GP clinic in and around Udupi. In fact, I remember in that 1 year, I would have covered almost around 200 GP clinics. So basically, this was and I used to tell them about this particular facility of de-addiction which is available in CSI Lombard Memorial Hospital. So the first one, first camp we did, because we wanted to have a community approach. The first camp was done in the primary health center Hiriyadka. In fact, why I'm telling you this is, since if you want to start a de-addiction center, one thing is you should make your presence felt in the community. So in fact, the first camp, it was a single day camp. Lions Club Hiriyadka and the Primary Health Center Hiriyadka, they sponsored the program. It was, in fact, again, the Lions Club members who had just started their Lions Club in this place called as Hiryadka, they chose a village called as Bommarabettu village, where, and also they made some posters on alcohol de-addiction in the primary health center. And to our surprise, there were 39 patients who attended the camp. And this camp effort was mainly by the primary health center Dr. Narendra, who in fact is practicing in a neighboring hospital now as an orthopedician, and of course the Lions Club. And I had convinced our Christian Missionary Hospital, CSI Lombard Memorial Hospital, to do the routine investigation. See, right from day one thing I have maintained is there is a need for a proper medical model. We cannot do any detoxification or any de-addiction treatment without proper investigation. I would say this is something I observe is missing in many of the community camps being done elsewhere. Even in some of the organizations in which I am also involved, I try to convince them that a routine investigation, we start from complete blood picture to liver function, kidney function tests. These are a must. And right now, after the inception of A.V. Baliga Hospital, we have conducted almost 33 de-addiction camps. Every year we conduct 1 to 2 camps. We have made it a point that the routine investigations are never compromised. So routine investigations were done, and of course the detoxification regimen based on the last drink of the person and also the amount of withdrawal symptoms he had. We started him on medications. Basically, we have been using benzodiazepines, and with a follow-up after 1 week at the PHC, then every month, first Saturday. And you are of these 39 on record, and you will be surprised till day. That is from 2001 till today, one psychiatrist visits the PHC Hiryadka. Right now, my colleague Dr. Deepak Malya is attending this particular place. So it is almost now 24 years. And every earlier it was first Sunday, now it has been changed to first Saturday. And till date, 2 of the patients who were treated then, they are still in contact with us. I'm not saying I don't know about the others, but these 2 people are in contact mainly because they also had relatives who are having some psychological issues. They are being treated in this camp. So this was our first effort. And mind you, it was an outpatient effort. So this created a lot of awareness in and around this place called Hiryadka, which is almost around 10 kilometers from the Christian Missionary Hospital to which I was working. Then the next thing was we took a little, what do you say, in today's terminology, I would say it's a braver step, because if I think back, I myself, I feel very tense how I managed the situation those days. So the first residential community camp, in fact, we copied from Sri Kshetra Dharmasthala. They were conducting camps like this at that time. It was almost 1999 they started. 2001 we started the first residential community camp. This was in a school, Merinal English Medium School, Barkur, in their October holidays. This was sponsored by the Catholic Sabha Barkur and the Indian Catholic Youth Movement. And this 7-day camp started on a Sunday and ended on a Saturday. So awareness camps at church, mass, and various schools of Barkur was conducted by this Indian Catholic Youth Movement. Psychiatrist, that is me, and then there was an ex-alcoholic lay volunteer and 2 nurses from the hospital. We were placed in this place all 7 days, and a lab technician on the first day was the other medical personnel. So what I used to do was, night I used to stay in the school, mornings I would rush to my OPD, and my nurses would manage the day. So this is one of the camps, awareness camps, which we conducted at this particular place in Barkur. So in this, 59 patients enrolled, and again routine investigations. I would do the morning rounds rush back to the hospital, come back in the evening. In between, the ex-alcoholic lay volunteer would manage. And of course, we started having some programs for these patients. Community leaders like the police inspector, the priest of the church, the PHC doctor, school teachers, they would come. And the follow-up was entrusted to the lay volunteer. And he would bring the patients to the hospital on a monthly basis. And we were not charging them any consultation fees. And we were giving them medications. So this is how we maintained a 1 year follow-up. So when we were doing this, the local one more Catholic Sabha joined hands with us. Not Catholic Sabha, that was a Saint Vincent Paul Society, another NGO. And they said they want to do a camp. And this was in the month of April. 44 patients enrolled in the camp. But again, as I was telling you, many times when I think back, I really wonder whether how I could venture into it, because there was one untoward incident in the camp where a resident was brought with severe hypoglycemia, and before we could do anything, he died in the camp. And in fact, we tried to do a lot of things, but we could not. But mainly because of the community support and the fact that immediate medical management was tried, and of course, people knew that he had come in hypoglycemia. Whoever had seen, there was no problem. And then, of course, what we noticed was there was a lot of burden on the nurses, lot of withdrawal symptoms, and a lot of burden on myself also, because we had 3 cases of delirium on the second day. I'm sure as you see more and more patients of alcohol de-addiction, you will notice that delirium is something which where we have to really we really face a lot of problems treating these patients with delirium. And of course, we noticed that this lay volunteer would misuse his position. Now, I am highlighting this because one more thing is, most of the de-addiction centers, they have these ex-alcoholic volunteers or these lay volunteers who are not trained. And many times this can be a problem because they may misbehave with patients because they do not have any background on medical ethics. They start extracting money, materials from relatives and the residents. So this is something which I want to bring to your notice. One thing in the 25-year journey I noticed was we have to, as much as possible, bring in more and more trained people. And yes, lay volunteers, ex-alcoholic volunteers, we do need, but we need to be very, very careful about that. And we could not ensure proper follow-up, as this lay volunteer turned defiant when I started questioning, and he left the job. So this was our second experience of community camp, and the third camp. And the third camp was something which gave us a lot of media attention. This was in the same place where we conducted the first outpatient camp. It was in the primary health center, Hiriyadka. Here, as a psychiatrist, I resided for the first 3 days, because at that time there was a MBBS doctor who was working in Hiriyadka, the same Dr. Narendra. He was quite enthusiastic. So we enrolled 49 patients. And this camp attracted a lot of media attention, as the then health minister, Kagodu Timmappa, he visited the camp. And in fact, till date, no patient from this camp is on follow-up with us. However, on an average, I told you about this Hiriyadka, there are on an average 40 plus patients still visiting this particular camp venue. So as a result of this, I could convince the management of CSI Lombard Memorial Hospital for a separate 10-bedded ward, and which was upgraded to a full-fledged 25-bedded ward, and I could convince them to appoint one medical social worker and 4 nurses. So along with this, we added what is called as this Alcoholic Anonymous meetings. See, actually, Alcoholic Anonymous is again a good organization. You can always use them, but only thing is we do not interfere in their functioning. Usually the Alcoholic Anonymous members, they themselves will run it. many of our patients treated by us will become members of Alcoholic Anonymous. They run it. So the first Alcoholic Anonymous in Udupi was started at the request of our hospital in Christian High School and one Gandhi Shatabdi School and MIT Manipal in 2002. So we started sending our patients to these Alcoholic Anonymous meetings. So again, there is a lot of things we should know. There are a set of hardcore Alcoholic Anonymous members who keep telling the patients not to take medical treatment, tell them that medicines can be dangerous, these sort of things. We should be aware of that. So, as I started this setup, there were some problems with the functioning of that Christian Missionary Hospital, CSI Lombard Hospital. And because of that, I had to end my association with them. And I came and joined the district hospital as a contractual employee. When I came there, again, there was acute shortage of hospital beds. There was no exclusive de-addiction setup. At least in private sector, we had it, but again, it would cost 600 rupees per day. Right now, if you look at the current, this one, it again costs almost around 1,500 to 2,000 rupees even for a general ward. And of course, there was social stigma for substance and of course for women. I am highlighting women because in our hospital right now, we have made a separate facility for women addicts also. That is why I am highlighting this particular thing. So we started continuing because there was no facility in the public hospital. We started continuing this camp approach with fixed number of days, same sensitization, key persons, I will come to that, and educational interventions. So basically what we started doing was we created awareness using the self-help group leaders, reformed alcoholics. Then a peculiar thing is the Ambalpadi temple. There they have this Darshana Seva. Those of you don't know what is Darshana Seva, there is an oracle. Every Friday, the oracle talks to people about their problems. I would say it was those days a sort of a therapeutic effect was there because of these oracles. So people would visit the oracle every Friday at a place called as Ambalpadi, and till date, our hospital runs a public clinic for alcohol de-addiction, where even medications are provided free by this Ambalpadi temple. So there we used to have our volunteers who would stand there, and the oracle would direct people with alcohol addiction related issues to these people, and they would bring them to the government hospital. And of course, we started distributing pamphlets. Basically, it started raising awareness about treatment for addiction, and of course, providing information about treatment accessibility. These were certain things which we started, and the Department of Psychiatry those days consisted of me, psychiatrist, a resident trained in medicine and psychiatry, Dr. Vasudev, who is now incidentally, he took up psychiatry and he is now a psychiatrist in district hospital. And of course, the clinical psychologist came from the KMC Manipal. Dr. K.B. Kumar was my teacher. He volunteered to come to these camps, and we started what is called as a de-addiction clinic at the district hospital premises on 26 June 2003, which was the International Day Against Illicit Drugs and Drug Trafficking. And we started Alcoholic Anonymous meetings on this day. And of course, we started off with the inpatient de-addiction facility. And we continued these community camps, as you will notice. One was conducted in a school, another in a chowdhury, another in this Janardana Mahakali temple, the same Ambalpadi temple, and the primary health center at Mudubettu. So this is the inauguration of de-addiction clinic by this.
Sir, can I disturb you? Excuse me, sir. Sir, your slides are not moving. If you could put it into the full screen mode, and we are not able to see these slides.
You are in which slide you are seeing now?
First only, sir.
Oh.
Introductory slide.
Oh, I am sorry. I didn't realize that. Hello?
Yes,
hello.
Sir. Yes, sir.
Yeah, 1 minute.
Yeah.
I didn't realize slides are not moving. I
thought you were in the introductory part, so
oh,
I also didn't.
okay. So basically,
So yet we are not able to see.
okay, 1 minute. Okay. Yes. Shall I send you the slides?
Yes, sir.
I think that is better. Some
Yes,
problem here, I think. I didn't realize only. ಅವ್ರ ಸ್ಲೈಡ್ ಫಸ್ಟ್ ಸ್ಲೈಡ್ ಇಂದಾನೆ ಕಾಣಿಸಿಲ್ಲ, ಅವ್ರಿಗೂ ಗೊತ್ತಾಗಿಲ್ಲ. ಹೌದೌದು ನೋಡು, ಅವರಿಗೆ ಕಳಿಸ್ಬಿಡ್ತೀವಿ ನಾವು.
ಸರ್ ತೋರ್ತಾ ಇದೆ ಈಗ ತೋರ್ತಾ ಇದೆ ಸರ್. ಕ್ಯಾಂಪ್ ಅಪ್ರೋಚ್, ನೌ ವಿ ಆರ್ ಏಬಲ್ ಟು ಸಿ ಯು. Maybe if you could move now and put it into full screen, sir.
Slide share, sir.
Slide share.
A volume button ಪಕ್ಕ ಇದೆ ಸರ್.
ಓಕೆ, ಈಗ
ಇಲ್ಲ ಸರ್, ವಾಲ್ಯೂಮ್ ಬಟನ್ ಪಕ್ಕ ಒಂದು ಬಟನ್ ಇದೆ ನೋಡಿ, ಸ್ಲೈಡ್ ಶೇರ್ ಅಲ್ಲಿ.
ಸ್ಲೈಡ್ ಶೇರ್ ಆಗಿದೆ. ಆಕ್ಚುಲಿ ಸ್ಲೈಡ್ ಶೇರ್ ಆಗಿದೆ.
ಇಲ್ಲ, ಶೇರ್ ಆಗಿದೆ ಸರ್. ಫುಲ್ ಸ್ಕ್ರೀನಿಗೆ ಹಾಕ್ಬಿಡಿ. ಅಲ್ಲಿ ಕಪ್ಪಿದೆಯಲ್ಲ, ವಾಲ್ಯೂಮ್ ಆಚೀಚೆ ಮಾಡಿದಾಗ. We are able to see now, sir. It's changing, it's moving, but maybe in full screen it would be better. Left, sir. Innan ಸ್ವಲ್ಪ left.
ಇಲ್ಲ ಅಲ್ಲ, ಇವಾಗ ಕಾಣುತ್ತೆ ಈಗ ಮೇಡಮ್?
ಹೌದು ಸರ್, ಕಾಣ್ತಾ ಇದೆ. ಮೂವ್ ಮಾಡಿ ಸರ್, ಸ್ವಲ್ಪ ಮೂವ್ ಮಾಡಿ. ನೆಕ್ಸ್ಟ್ ಸ್ಲೈಡ್ ಹೋಗಿ. ಮೂವ್ ಆಗ್ತಾ ಇಲ್ಲ ಸರ್. ಟುಡೇಸ್ ಡಿಸ್ಕಷನ್ ಸ್ಲೈಡ್ ಅಲ್ಲೇ ಇದೆ.
ನಿಮಗೆ ಇಮೇಲ್ ಕಳಿಸ್ಲಾ ಮೇಡಮ್?
ಕಳಿಸಿ ಸರ್. ನಾನು ಇಮೇಲ್ ವಾಟ್ಸ್ಆಪ್ ಮಾಡಿದ್ದೀನಿ ನಿಮಗೆ.
ಮಾಡಿದ್ದೀರಾ?
ವಾಟ್ಸ್ಆಪ್ ಮಾಡಿದ್ದೀನಿ ನೋಡಿ. ಹೌದು, ಈಗ ಮಾಡಿದೆ ಸರ್.
ಕಳಿಸಿದೀನಿ ನೋಡಿ. ಅಲ್ಲೇ ಇದು ಮಾಡೋದು ಒಳ್ಳೇದು ನೀವು ಆಗಿದ್ರೆ. ಸಮ್ ಪ್ರಾಬ್ಲಮ್ ಇದು.
ನೋಡ್ತೀನಿ ಸರ್.
ಬಂತ ಮೇಡಮ್?
ಇಲ್ಲ ಸರ್, ಬಂದಿಲ್ಲ. ಬಂತು ಸರ್, ಈಗ ಬಂತು. Okay. So you continue. You stop sharing this slide. I will take over. I download this and.
Okay. Sorry for the inconvenience.
No, sir. That's okay, sir. Please continue, sir.
Yeah. Slides ಬಂದ್ರೆ I'll continue better. ಆ ಡಿ ಅಡಿಕ್ಷನ್ ಇದು ಕ್ಲಿನಿಕ್ ಅಲ್ಲಿವರೆಗೂ ಬಂದ್ಬಿಡಿ, ಅಲ್ಲಿಂದ ನಾನು ಮ್ಯಾನೇಜ್ ಮಾಡ್ಕೊಂಡು ಹೋಗ್ತೇನೆ. ಥ್ಯಾಂಕ್ ಯು, ಥ್ಯಾಂಕ್ ಯು. ಸೊ ಇದರಲ್ಲಿ ನೀವೊಂದು 15 ಸ್ಲೈಡ್ಸ್ ತಗೊಂಡ್ಬಿಡಿ. ಇದಾದ್ಮೇಲೆ ನೆಕ್ಸ್ಟ್ 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 ಹೋಗಿ, ನೆಕ್ಸ್ಟ್ 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 ಯಾ ಇಲ್ಲಿರ್ಲಿ. ಯಾ, so basically this is what the inauguration of the de-addiction clinic, this was done by Sri Annaji Ballad, who in fact donated at that time 1 lakh rupees to district hospital. I'm talking about 2000, where for establishing a de-addiction center in the government setup. So it was something first of its kind. Nobody had in Karnataka at that time, other than NIMANS, there was no de-addiction facility in any of the places. So we started the first de-addiction clinic. Next slide, please. As a part of this, during this de-addiction clinic, we started doing camps in and around the district hospital, because what happened was there were no beds. So basically we started with the, again I repeat, the treatment process, which consisted of routine blood investigations, detoxification, then conducting psychoeducative sessions, recreation and religious activities, Alcoholic Anonymous meetings, family sessions. And next slide, please. I'll come to that. You will see this was a clinic in a school near to district hospital. Basically there we conducted a 7-day de-addiction camp. Sitting is me and one MBBS doctor who is now the psychiatrist at district hospital, Dr. Vasudev, and one social worker and an ex-alcoholic volunteer. Next slide, please. So basically common drugs at that time, maybe like I'm telling you, because what we have used, diazepam, lorazepam, and even parenteral multivitamin injections, but we were not using any IV fluids. IV lorazepam or haloperidol were used in around 10 patients, and nitrazepam as SOS. Next slide, please. We started conducting 5 sessions of 1 hour duration, basically on harmful effects of alcohol and tobacco, high risk situations, how to control the craving, coping strategies, relapse prevention. And next slide, please. This is a photo of a psychoeducation class. This used to take place in the blood bank of district hospital. In fact, there was no place, so we were using these sort of things, nearby school, in the same campus, I mean the adjacent campus, as well as the blood bank, where we would pull up our patients and start conducting programs. And we had one social worker, apart from me, psychiatrist, and 2 nurses. This is the staffing pattern those days. Next slide, please. So basically we started inviting community leaders, basically the college teachers, police officials, lawyers, priests, local political leaders, even the self-help group leaders, NGOs. These were the people who would also come to these places, to the these camp sort of a thing which we were doing in district hospital. Next slide, please. And of course, we used to have recreation and religious activities also. Community members would conduct, basically we were involving these college students from first grade college. There was this youth Red Cross. They would come and participate. And the last day was reserved for patients and their family to conduct recreational activities. And those days there was no mobile, television, cards, carom board. These were the things we used to provide. And we used to have religious teachings from all different religions, and of course religious songs and Shramadan activities. You will notice this. This was a special dance by a child of a camp resident those days, which was very something which was very entertaining to all the residents of the camp. Next slide, please. And of course, this Ramadan activity, this was in the premises of the hospital, these patients doing their Ramadan, the last 2-3 days of the camp. In fact, one of the camp residents here, he lived till his death around 1 year ago to cancer. He was a very staunch supporter of this camp approach, and he would come with us to different camps. He died of oral cancer, unfortunately. This is that religious leader giving a talk in this our camp at district hospital. Next slide, please. Recreation, again conducted by the community people. Next slide, please. And Alcoholic Anonymous meetings. The recovered alcoholics, they would every day, whenever the camp was being held in the premises, there itself 6 to 7 every day they would come and conduct these Alcoholic Anonymous meetings. And on the last day, there will be meeting of spouses with wives of a AA member conducting it. And till date, even in our hospital, we have continued this particular thing. Next slide, please. So this is an Alcoholic Anonymous meeting that was taking place in the this particular camp in district hospital. This was Mr. John. Is no more. He was again a very enthusiastic member, treated by us and lived till his death away from alcohol and conducting Alcoholic Anonymous meetings. Next slide, please. And we have family sessions. Again, this particular thing which we have done, 5 sessions of psychoeducation and 2 sessions of family education. This even till date in our hospital in Baliga, we are still following the same thing. We talk to them about relapsing nature of illness, role of family in relapse prevention, information regarding disulfiram. You may be knowing we psychiatrists use a medicine called as disulfiram as well as other medications. We give information to the family about this particular thing. Next slide, please. And of course, disulfiram, what we do, like we take written and informed consent from patient as well as family. Without the consent of the patient, we don't give medicine, and we continue it. Next slide, please. Next. So the awareness, basically what we realized is awareness activities and activities during the camp and follow-up in the de-addiction clinic. This was very essential. Next slide, please. So totally in district hospital, whatever we did, almost around 143 patients were there, and in fact 4 patients we had to shift to the hospital. That is the mainly the so-called ICU. Those days 4 patients had delirium and 4 patients had to be shifted with complications, and of course they did recover. Next slide, please. And the follow-up activity was every Tuesday. There will be this de-addiction clinic at district hospital, and they had to come to this center every Tuesday. Initially, they used to come every week for 4 weeks, then every 2 weeks for 6 weeks, then monthly. And in the same premises, we had this alcohol de-addiction, Alcoholic Anonymous meetings. And after 3 months of the camp, we started having what is called as the Punaschetana Shibira. It was like a revision where we would have, as I told you, there were 143 patients. So basically, at least 20-25 would gather to this Punaschetana Shibira once in 3 months. You see this. This was the district hospital de-addiction clinic board, where we had mentioned the rules and how they have to attend to AA. It is in Kannada. I am sorry. So basically, it was one of the. In fact, to be frank, those days our hospital became well known. The district hospital became well known mainly because of this de-addiction activity. Next slide, please. So you see, this is how the patients used to wait in the de-addiction clinic. There were 2 queues. One queue was for psychiatry, another was for alcohol de-addiction. They would wait, and I was sitting in a chamber adjacent to it. They would come. So this Tuesday, we used to see almost more than 100 patients as a part of this de-addiction activity. Next slide, please. So conclusion is, since there was no place, we started having something like a camp approach for fixed days in the premises of district hospital or the compound of district hospital. And we, with the professionals, being with the people, conducting awareness camps, involving community, and it was a cost-effective method. So this is what we noticed. So actually, this made us, in fact, quite popular. This alcohol de-addiction was a popular activity of district hospital, and till date, it is being continued by Dr. Vasudev there. And in fact, 2009, I had to quit district hospital because Dr. Vasudev joined as a full-time psychiatrist. Next slide, please. And of course, as I told you, certain things we noticed was premature discharges were less whenever you do it in a camp-like activity. Unlike if you do admit them in a hospital, here this group effect and of course the social influence by family plays a major role, and of course the religious activities, since we were involving the Ambalpadi temple, which was a major donor, and of course the strict patrolling by community leaders and some NGO volunteers, sometimes the health center staff who were involved, and of course group cohesiveness was noticed where elderly patients were looked after by younger patients. This was something which I noticed. Next slide, please. So the lessons we learned. Next slide, please. We started forming a separate de-addiction center under this A.V. Baliga hospital, and we started conducting regular free camps on 1st January and 15th August of 10 days duration. So in fact, till date, 33 camps have been held in this Navajivana premises. That is my current workplace. Which we call, in fact, 8 camps have been conducted exclusively for primitive tribes of the district. And in the last 4 camps, 20 women, as I was telling you, women de-addiction facility is something which is a must. In fact, we have started a separate ward for women, which is called as the Spurti ward. Even today, there are 4 patients admitted in this ward. It is a 7-bedded ward, in which 4 patients are there, women patients are there. And of course, the alcoholic anonymous meetings are continuing in district hospital. Then one more hospital called as Goretti Hospital, they also started joining us, and they have a small de-addiction setup, as well as our A.V. Baliga hospital. Now I'll come to the current features. Apart from this camp approach, what we have done is we have a 30-bedded ward in which there are 7 beds reserved for women. And we have a regular informative class for residents by psychiatrists, social workers, and dentists. Basically, dentists talking about tobacco. And what we have realized is when I started, I was only 1. Now we are 5 psychiatrists, 4 full-time and 1 part-time. And we conduct family meeting. As I told you, family is a very important thing on 2nd Friday and 4th Friday of every month. And we honor abstinent alcoholics in the family meetings. And we started being approached by government. Government gave us money to conduct camps for these primitive Koraga tribes and also the police of our neighboring Uttar Kannada district. And Alcoholic Anonymous meetings, we send our patients 3 days in a week. So these are the things which are going on in our hospital. Next slide, please. So, and right now, as I told you, we are 4 psychiatrists. There are 3 MSW qualified counselors, 2 MPhil psychiatric social workers, and previously we had employed 2 recovered alcoholics as lay counselors. Nowadays, we don't have them. This is the workforce that treats 30 people. And apart from that, just like in any hospital, we have nurses doing for these 30 beds, we have 3 nurses doing 8 hours duty. Almost around 9 nurses are there. So this is the core team which looks after the patients. Next slide, please. So what we have done is now we have made 15-day minimum. They have to be admitted in the hospital. And our camps, as I told you, we conduct camps twice a year. Once is for sure, twice. The second one, because each camp costs us around 3 lakh rupees. Whenever we get donors, we conduct the second camp in the year. Otherwise, this 15-day hospital stay, and it works out to almost around 1,500 rupees per day to the patient. Of course, we subsidize it sometimes when we receive donations. And 30% of the admissions are involuntary. Sorry for that mistake there. With force. With force means force of the family. As per the Mental Health Care Act, we in fact follow the Mental Health Care Act guidelines. And zero violence facility and specialized 4-bed facility for delirium cases. See, one thing which is going to be very challenging is managing this delirium. As I told you, there are days when this 4-bedded facility is not enough. We'll have to have 1 or 2 special wards in the hospital which has oxygen supply. We convert them into delirium wards and admit patients there. Managing delirium is something which you should be probably, I feel, I mean, very frankly, you may have to take help of evidence-based medicine, I mean, MBBS or MD in psychiatry or MD in general medicine. This is what I feel. This is something which you should be prepared for. And of course, strict adherence to Mental Health Care Act guidelines, because to be on the safer side, so that tomorrow nobody will question you why you admitted. And of course, zero violence policy. Other than restraining the patients with permission of the nominated representative, we never do any. That is why, in fact, I removed all these, what do you say, no ex-alcoholic volunteers and all, because many times they have their own crude methods of helping people, and they may get you into problems. This is something which I have seen in neighboring de-addiction centers, and many a times we had to run to their rescue. That is why I am telling you. So these getting the Mental Health Care Act, and in fact, MD in Ayurveda can also apply for MHCA registration if he has done Manasa Roga. So I don't think there will be a problem. So strict adherence to these guidelines when you are admitting involuntary patients, and also reporting it to the Mental Health Review Board. These are certain things which I want to caution you about, because these are even alcohol de-addiction comes under the Mental Health Care Act, and we should try to enforce it to the in its letter and spirit. Next slide, please. So basically, as I told you, we have a comprehensive treatment approach, anti-addiction lectures. We also have, since we have 2 MPhil people, they conduct group therapy, because these are things probably you will have to have MSWs and MPhil. And even if you can get MPhil clinical psychology also, where it would be nice. And of course, a proper psychiatric evaluation of the patient and physical health assessment. One thing I have realized is almost 30 to 40% of the patients will require help of a hepatologist or a general medical person. We have had acute pancreatitis, a sudden death in our ward. We have had subdural hematomas. They fall somewhere and come, and on the 5th day, 6th day, delirium does not subside. Then we get a scan done. There is a big hematoma. So physical health assessment is a must. And again, this is something I want to caution youngsters, because the more careful you are, the more earlier you can pick it up. And of course, we do allow our counselors, especially the MPhil and MSW people, we have trained them in cognitive behavior therapy, relapse prevention strategies, family counseling. And recently, we have added this Children of Alcoholics Support Group. Basically, in fact, incidentally, this week is what is called as a Children of Alcoholics Week. So we are conducting programs in our hospital for these children of alcoholics. And of course, we also have a yoga session every day morning for these patients. So I would like to point out that we follow what is can be known as the holistic approach. And aftercare program, this is very important. Again, I would like to tell you, 1 year follow-up, we have made a protocol. We have a community social worker. He will first call up these patients, remind them on the day they have to come for follow-up. It will be telephone. And if they are not responding, basically what we do is we do in-person monitoring. We go and bring them. And at times we have given them free 2 beds, free 2-day beds whenever they have had a relapse. In fact, right now, we have 5 sheltered employment opportunities which have turned out to be successful. We have a hospital strength is 100 plus 104 staff are there in the hospital. In that, 5 of them are actually our ex-alcoholics. They are working in various capacities, including one of them is a patient care executive, 2 of them work in reception, one of them works as a security guard, like this. And we send these patients to regular AA meetings. We send to 3 different places outside, and once 4th meeting will be in our hospital. We in fact give them free transport to this Alcoholic Anonymous meeting from our facility. So this is another thing which is very important. Basically, you have to liaison well with this Alcoholic Anonymous, but never interfere, never involve yourself in their politics. This is again something which I would like to say. I quote Alcoholic Anonymous itself. They say once an alcoholic, always an alcoholic, and they are all character defects. Many a times what happens is these character defects come into picture. They start telling the patients, don't take medicines, medicines are harmful, these sort of things. I usually use the term Divya Nirlaksh. I think in Hindi also the same thing. I don't interfere. You speak whatever you want, I continue my work. So basically, this is something I want to advise all of you. If you are wanting to liaison with them, but don't involve, don't respond to their criticism of our treatment and all. Just keep quiet, it will die away. Patients who are benefited by us, they will continue to come to us as well as go to their, and definitely it helps. Something I have realized is Alcoholic Anonymous is a good thing, but for their approach at times. Next slide, please. This is the medical integration. As I told you, I already spoke about this. One is we require a good physician. We have a physician who visits our hospital twice a day, and a gastroenterologist who is in the neighboring hospital, and a good dental care services. We have picked up because, see, alcohol de-addiction people, they have a lot of this use of tobacco. In fact, we have in our 25 years, we have picked up at least more than 15, 16 cases of oral submucosal fibrosis. I would say it is much less, but still, because we have a very efficient dental program, every patient is subjected to dental referral, so that we don't miss out these things. And of course, the psychiatric comorbidity management, I would like to compliment my colleagues, Dr. Deepak Malya, Dr. Virupaksha, Dr. Manas, who have been, and Dr. Vasudev, who have been very meticulous. in trying to find out psychiatric comorbidity. I'm not going into it. Probably sometime we can have a discussion on the psychiatric comorbidity we are seeing in de-addiction. It's quite high, and you definitely your Manasa Roga specialist role is very much needed. So basically what I would like to say is we basically have been following a holistic approach: medical treatment, psychological support, and social rehabilitation. We have rehabilitated a lot of patients, and we have been strictly adhering to ethical guidelines, integrating various therapeutic modalities, and of course we give a comprehensive aftercare support, involve the family, and of course community engagement. We have 4 satellite clinics. Madam told you about our satellite clinics. In fact, we ask the patients to follow up there because it is near their house. They can come easily and they get free drugs. That is how we have been able to manage this program. Next slide, please. And of course, integrating technology. See, now what we have done is every Thursday we have a conference call facility. Every Thursday for the last 56 weeks we have been running this program. One psychiatrist or our psychiatric social worker will be available to the patients. A conference call will be there. Almost 30-35 people join this call, and we select one topic. Our psychiatrist or the social worker will talk about it. This happens every Thursday, and our patients can join. Basically, this doesn't require smartphone. I can send you more details of this. Those of you who are interested, you can contact me. You can collect my contact details from Dr. Shobha. And definitely, this is one facility by which we have been able to keep in contact with our patients regularly. And of course, we have been conduct certain research programs also are going on in our this one with KMC Manipal. At least 6 to 7 theses basically on alcohol de-addiction. They have taken place at our place. And of course, our community outreach. We conduct a lot of programs in rural areas, temples, schools to raise awareness and provide early intervention. We also provide regular training and capacity building programs for not only our staff, but neighboring places. So the value additions, I think that slide is repeated. Next slide, please. Next slide, please. So this is the current, what I am telling you. Every year, February 2nd, second week, we conduct what is called as a Children of Alcoholics Week. Again, thanks to my colleague, Dr. Virupaksha. He is the kingpin behind this. We conduct regular Children of Alcoholics program. For these children, in fact, what we have noticed is they have a lot of problems. They have specific learning disability. They have anxiety, depression. They feel insecure. There is a history of, many a times there are a history of sexual abuse, maybe because of the father's alcoholism. There is somebody else in the family who misuses the kid. So many things we have started observing. So this is something, again, which we have added as a part of our holistic program. Every year we conduct these programs. Yeah, next slide is again the facts that have helped us. Awareness talks, I told you. And of course, TV programs, community camps. Basically, I'm summing up what are the things you can do in order to have a de-addiction center. Street place. In fact, the MSW students who are posted in our hospital, they are compulsorily trained on the street place, making posters, conducting rallies. So these are things which you should think of. Next slide, please. So I think I'll stop at this. If there is time, I am very sorry. Initial slides, I was not aware. I am also not very used to these things. Very sorry for the inconvenience. Okay, any questions? I am open for discussion. I think I saw one question. Yeah. I'll stop at this. And I thank Madam Shobha Bhatt for this opportunity because I feel really happy to present our experience. So in a nutshell, I would say community approach. This is a problem of the community. and we need to have a community approach rather than a hospital-based approach. This is something which I have learned. Thank you.
Thank you so much, sir. We have a question on the chat box. Sir,
Yeah.
how can we start a full-fledged de-addiction center, as we will require association of modern medicine in initial stages? Can we start center by taking in patients who had completed a first line of treatment in modern medicine?
See, basically, what I feel is maybe you should have one is in your team a MBBS doctor who is trained in de-addiction, at least. Because I don't know about what I have realized because I have a lot of friends in Ayurveda also. See, one of the things would be challenging thing would be managing the de-addiction. I mean the detoxification, the management of delirium. So basically, if possible, a psychiatrist, or if not, see, NIMANS does regular training programs for MBBS doctors. I am sure you will get somebody with this, so that you are safe and you are able to manage see, the most challenging aspect is managing the withdrawal the first 4 or 5 days. And I will tell you, you require many a times a regular ICU. In fact, as I told you, we have a 4-bedded ward. It is a proper ICU. We have even a defibrillator, all emergency measures, because we have had problems. We have had patients go into delirium. We have had patients who have developed hematemesis. We have had patients who have had a MI. So early diagnosis, and of course, we don't do anything there. We immediately shift him to other hospitals. I think you also should plan something like that. If you want to have a full-fledged, probably the scope of this lecture itself is that establishing a de-addiction center. And again, I repeat, try to medicalize it, because there are many people who will tell you we have conducted camps without any investigations. I feel it is wrong. I feel being medical people, we need to be, at least we cannot conduct, it is a community problem, no doubt, but it is a medical problem also. So we cannot leave the medical issues. We can't say that we don't bother, we will treat like that. So my advice would be have a maybe a holistic approach. You are there with that modern medicine. I don't know how your institution rules and all. Maybe if you want to set up a de-addiction center, I would advise please have a MBBS doctor also trained in de-addiction. That is something, again, I repeat, because he should know how to treat a seizure. He should know what medications to be given. Then if the patient's bilirubin is very high, which is the benzodiazepine to be used. And if the patient has things like diabetes, then what are the drugs to be avoided? These sort of things become very important. So the initial, maybe the first 4 days, because if you say you are going to have only patients treated in modern medicine, they come later, it is little difficult. You may not get so many patients. There are people who want help in de-addiction. They will come to a de-addiction center. That is why my experience. See, many people told me it is very difficult to run this setup. And I will tell you, I should thank A.V. Baliga Charities, which has stood by me, and especially during COVID, a huge loss we would have suffered, but for my parent institute, that is A.V. Baliga Charities. But we have been able to sustain. We have right now 24 occupancy out of 30. And of course, there are 4 more. In fact, the female ward, what we have done is, female de-addiction ward is adjacent to the female psychiatry ward. And again, there are 3 people. So if you look at it, out of 30 beds, 27 beds are full. So there will not, I would suggest, have MBBS person in your team who is trained in de-addiction and continue it, instead of saying that you will only take up patients treated in modern medicine, then coming here. It may be little difficult, I feel. But still, if you want to do that, I have given you this, and you can contact me if you want any, whatever slides, the IEC material which we are using, I can lend it. And I would like to place on record help of TTK Foundation, Chennai. In fact, I forgot to tell you, I think I missed out during my preparation also. My inspiration was TTK Foundation, Chennai. I request those of you who are interested, please visit TTK Foundation, Chennai, where they have a very comprehensive de-addiction facility, and go to their website. Lot of help like reading material, even in Hindi, even in your local languages, it is available. So I should have actually included, maybe in my future presentations, I will include it. I want to follow them anytime you want any material or any help. I am open for it because this is one facility which everyone should develop. At least if there is one good facility in a district, say I will tell you the scope. Almost in every district there are, as per studies, roughly around 1 to 1.5 lakh. Like see, each district in India, there are almost around 731 districts now. They say that each district there is 1 to 1.5 lakh people who need help for addiction. So basically, if each district can start having a comprehensive de-addiction setup, we can work wonders. That is what I would like to tell you.
So before we wind up, we would surely like to listen a little about the Alcohol Anonymous meetings.
Yeah. See, this Alcoholic Anonymous, it is based, it is an international organization. It is there in more than 100 countries. So ex-alcoholics, people who have left alcohol, what they do is they conduct meetings. This is based on self-help concept. They have their Bible called as Blue Book. So they follow it. They follow certain steps. It is basically, they claim it is a spiritual part of medicine. They also say that alcoholism is a medical disease, and so they say that they look after the spiritual component. So in our this one, I first started this Alcoholic Anonymous with there was one Mr. Walter, again he is no more. He was an alcoholic. He gave me this message of what is Alcoholic Anonymous. He started the first Alcoholic Anonymous group in Christian High School. So right now we have 6 such groups. This is started by ex-patients. I mean patients who were treated for alcoholism, who give up alcohol. Even they relapse sometimes. Okay, keep it in mind. See, there, not drinking alcohol is not the criteria. Wanting to leave alcohol is their criteria. So people who have left alcohol for 1 year, 2 years, 5 years, 10 years, like that, they give lectures on how they quit alcohol, what they did. See, because this becomes very inspirational to our patients. Of course, there is a set of patients who get irritated. They come and tell me, sir, they tell the same thing in the meeting. I don't want to go to the meeting. You will see both type of people. So, but there is another subset who likes it more than our what do you say, our lectures on preventing relapse and all. They say, sir, we'll find Alcoholic Anonymous interesting because it is experiential. So these meetings, they are of 1 hour duration, and basically there will be 4 or 5 speakers. There are 2 types of meeting, what is called as open meeting and closed meeting. So the open meeting, even I and you can go. Basically, anybody from the general public can attend. I have attended almost around 30-35 of their meetings in my 25 years, just wanting to know what they do. So what I have realized is it has some therapeutic effect, because somebody tells how he destroyed his family, how he destroyed himself. So how he was helped by Alcoholic Anonymous. And really, if you go by their Blue Book, there are people I have seen, they help the other alcoholics so much. There is so much of this in psychiatric terminology. We talk what is called as sublimation. They basically do a lot of good things. After they leave alcohol, they help others. They help them to remain sober. So basically, it is a fellowship of people who want to quit alcohol. And they have their own method. We don't interfere. They follow, like they have their 12 steps. They give lectures on this. They say 1 day at a time. Don't say that I will ever leave alcohol. Today I will leave. That sort of a thing. And they have a concept of what is called as rock bottom.
Hello. Hello.
Yeah. So
Yes, sir,
I
we
think
were.
I lost the connection a little bit. So basically, it is a fellowship of people who want to quit alcohol on their own, and they participate in the lectures. See, I mean their deliberations, and we send our patients 3 days outside, and once in a week, every Saturday, they meet in our hospital itself. That's how we have been going.
Thank you so much, sir. I guess if there are any questions, kindly raise your hand and type the question, or you can unmute. We will unmute you. Dr. Ashish. Hello.
Yes, ma'am.
Yeah, I guess there are no more questions. In that case, maybe we can proceed.
Thank you, ma'am. Am I audible, ma'am?
Yes, Dr. Ashish, please continue.
Thanks for a wonderful session. Respected Dr. P.V. Bhandary, esteemed dignitaries, faculty members, and the participants. It is my privilege to extend our heartfelt gratitude to Dr. P.V. Bhandary, sir, for his insightful session on establishing a de-addiction center, need for a strategic planning. Your expertise and practical insight have provided us with valuable guidance on the challenges and essential strategies for setting up effective de-addiction services. Sincere thanks to our respected Shobha ma'am for ensuring the smooth execution of the webinar. Special appreciation to all the participants for their active engagement, making this session more enriching. Lastly, once again, I want to thank Dr. Bhandari sir. We truly appreciate your time and wisdom, and we look forward to future interaction. Thank you one and all. Om Dhanvantare Namah. With this, we conclude our session.
Thank you.